There's a t-shirt here. So we were very popular during COVID for teleconsultation, but coming now, so this is just a 5-slide presentation. More I'll talk about things which I've seen as an outsider, with working with a lot of hospital entrepreneurs, medium-sized, small size across the country, they take my help understanding what they do. So this is just, it'll resonate with you. So even before I start, I can ask participation, audience participation. What do you think are the 5 big mistakes? Anybody wants to take it? Okay, well, we'll do one thing. Let me share something and then we will discuss. So I'm trying to put this in 3 parts. One is financial management related, one is human resources related side, and one is technology and process. We talked about technology and process, etc. So I will cover something around that from what my experiences are. So I use this word emotional capex, and I think all the doctors here who are doctors or hospital administrators will resonate with that. What is emotional capex? Everybody wants the latest equipment, the best equipment. Somebody sitting in Khurda, in a tier 3 city near Bhubaneswar, wants a 3 Tesla, where they will not find a single patient who will be able to even afford that service at that place. But the doctor believes that he should have that, okay? And he goes and invests in that machine. There will be a place in Trichy. It's a small town where you can manage, possibly you get only accident cases. Maybe you can manage with an 8-slice CT scan, but then you have somebody having a 128-slice CT. He doesn't even do a neuro case. He's an orthopedician, but he has gone and invested in a CT. Now, these emotional capexes are the first set of stress and the first set of mistake which doctors do. The other big emotional capex what the doctor does apart from the equipments are making their cabin the best place in the hospital. I think it will beat 5-star hotels. In the hospital, the only place you know the boss is here because of the cabin and the way it has been decorated. How I know where doctors have created secret lifts to access their OPD room so that nobody knows where it's in the OPD room or it's in the OT theater. Okay, so this is the other place. So these expenses are made not based on the requirement of the hospital. You will find granite being used where it only adds to the cost. Patient safety is compromised where if it is used in wrong places. But we end up using granites. We end up using things which we should not use. But we'll spend money, Italian tiles. Nothing adds to patient care. It is not going to help anything in the patient. Not the patient is going to pay for you, but you end up spending money. So this problem of small hospital doctors of doing this emotional capex is one of the biggest problems or the financial mistakes which all hospitals do, which whom I have seen. Okay, I didn't get the photographs of those hospitals. I have shown the emotional capex done on their cabins or their front offices for their personal things. The primary doctor does that. So what happens if you do a emotional capex? You have 2 situations. You have a situation of an unsustainable debt. You don't know where the money is there. I will give you examples of hospitals which I have worked with in Hyderabad and other cities, where once the hospital was made, we didn't know how to start it because there was no money. It is like we're building our own houses. We buy a nice house. The last thing we compromise is we don't have money to buy tube lights because all the money has gone in building fancy kitchenettes, fancy fridge, there's that, but we don't have money for basics. So unsustainable debt is another big mistake which happens. Dr. Deepti talked very well about the working capital management as an issue, because I think all the doctors struggle to pay or find cash at the end of the month to pay salaries to the nurses. Everybody is searching for the cash at that point of time. You are searching for a friend who can give you money. You are looking at the finance guy. You are looking at so many places. Money is not coming. Billing is not happening. And there is a problem. And you don't have working capital to pay the cash. Now this is standard challenge with all hospitals. Then they keep a flexible way of making salaries paid between 31st and 7th. Someday we will pay, and which creates the biggest uncertainty for the staff, right? So So what happens is, if you have a higher capex, if you have spent more money than what is required for the building of that hospital, morning session had the concepts of how many square feet, what rate, what this, and what can be the cost per bed, etc., all that. Having said that, when you're building a capex or a hospital, please be sure that your hospital is going to run in losses for 6 to 8 months after you start. It will never make profit on day zero. It's a 9 to 12 months journey, right? It is not that you open a hospital, next day people start forking it and you have all 100% occupancy happening, and 100% occupancy never happens, 70-80% occupancy happening and everything is hunky-dory. It doesn't happen that way. So those cash also has to be created and kept aside when you're building hospitals, as resources as with you. So the problem is that these are the problems. Working capital problem is, as Dr. Deepti was saying, you should have financing, you should have bank loans, you should have factoring. Now those are solutions to a problem. The problem is you are not seen this happening, you have not planned for this cash because you have gone and spent much more than what you could have incurred for. So the problem with unsustained capex is about debts, and once debt comes you have to pay the EMI. You know what is the problem of the EMI? You are actually taking the money from the business and giving to the bank. So money has gone out of the business. So patient has given you 100 rupees, you have to pay 20 rupees salary, but you are not able to pay salary because that money has to be paid as EMI. So you are looking for that money, and the other 80% money goes to the vendor. So if you have more debt, you are taking the profits and giving it to the bank. So I have seen bank becoming profitable. Vendors are okay because they get the money for this thing. Patient is okay, but doctor doesn't know what to do after that. Because he doesn't know where the money is, right? This is again, Dr. Deepti talked about it. So I don't know her, I have not met her before, so slides are similar, so sorry for that, but the same problems. So one of the biggest problem in hospitals is embracing technology. She talked on the side of the medical equipments. She talked about biomedical equipments and other things. For me, I think for all of you, and one thing she talked more about, billing, right? Everybody has a billing issue. So I think all of you have to focus on something called as, if an indent is raised from the store, is it becoming cash? Am I able to tag it to the bill of a patient? If I am not able to tag it to bill of patient, then it is my cost. If it is my cost, how am I recovering? I think that transparency has to happen in your billing system, in your accounting system, in your processes. Billing is the core engine of things. People do so many things. In a large hospital, a doctor may admit a patient in a general ward, get the surgery done in general ward, and post-surgery he will upgrade him into a higher ward. The problem is that is hospital has the money, because if it was in a higher ward, then the billing would have been different. General ward billing is different. So that is the kind of leakage which is happening, and the hospital will lose its financial stability. Doctor is manchevadu. He has helped the patient, but hospital has gone down the tube. Okay? So what happens is, if you don't have processes and technologies, like Dr. Deepti gave an example of, if you have sent a cotton thing to, or syringes to the ward, where has it gone? It's a cost to you. Could we recover from the patient? We know that diapers are billed, adult diapers get billed more than what patient has consumed. So there's a billing dispute around it, because we have not put a process or a control of managing that indent rightly. Patient will come and say, how my patient was here only for 2 days, you have billed me 10 diapers. But the store guy has issued 1 pack, he doesn't know where it has gone. When it comes to billing, he picks up 1 bill and he adds into that bill. Right? So these are problems of the system, and we don't focus on that, and that creates a lot of other business issues. So please there's no one HIMS system in this country. There are 400 HIMSs, depending upon 400, 500, I don't know how many are there, I have lost count. So you have to pick up a right billing HIMS system, or when I say HIMS system, it includes clinical side of it, because you have to have records for NABH and all that stuff, inpatient details, discharge data, blah, 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 to inventory, to your accounting, and to your billing. I think one principle all hospital doctors should do is ask your accountant, at least on a morning or the next day, tell what was the amount billed, has the money gone into the bank or not. One simple check every day. And that is very important for small doctors. I have received 1 lakh rupees today, 20,000 cash, 60,000 credit card, for 20,000 bank deposit. Has it gone or not? And the cash has been deposited or not? If that basic control is instilled by you, you will be able to manage the system much better. Right? This is another challenge I see in hospitals. I see doctors as Kamala Hassan, Sagalakala Vallaban, Dashavataram. Everything he knows. Admin, OP, registration, billing, discount, concession, everything. But he is not able to focus on his practice, because he spends more time on only doing this. And this is a big challenge for small and medium hospitals, because it's driven by the primary doctor. So one request which the previous speakers in the previous session spoke, please get good professionals. They don't come very expensive. They save a lot of money to you. They bring a lot of streamlining the process, which helps you to review and spend say possibly 1 hour a day to ensure that your non-clinical controls are in place, versus you spending 4 hours a day, which would be more beneficial if you sit in your OPD chamber and do practice and possibly build the hospital and get more patients into the system. So this is one other challenge. So this is mistake number 4. And I'll go with one last mistake. This is the last from my side. None of the doctors think of a succession. They don't know what to do. There is no second generation. I have not seen second generation successful. Very few. Apollo is one example where multi-generation they have been able to create an institution. I am seeing large hospitals, when they become large, like KIMS or like AAG, still I don't know who is the second generation. It's going to Care Hospital didn't go to a second generation. None of the 9 original founding doctors second generation came into it. It went to a private equity, it went to some other place. But they transitioned it out from that. We see in small hospitals, we don't see this succession planning happening. I have seen multiple cities, multiple hospitals, multi-doctor collective practices, where after 25-30 years they don't exist. So these are the 5 things I think from my side for you guys to think and ponder. More than happy to any questions around this. Thank you.
Do we have any questions for both the speakers now?